okay if I start, Dr. Kazori?
Yeah, sure, absolutely. I just want to thank you again. You really didn't have to do this presentation. It's just the dedication that is exemplary. I think we have seen quite a few different settings where people have been presenting in unusual circumstances, but I don't recall having seen anybody present a renal grand rounds from a hospital bed. So I am obviously very thankful. At the same time, I'm just hoping that you will be surprised by your speedy recovery and you get us really some good news very soon. I know that you need it. So
Okay.
yeah, and I know that you have 345
No,
for the
Dr.
audience.
Kazori, that I'm sorry. Don't be. Yeah. But so let me just preface that I took 10 milligrams of Oxy IR about 15 minutes before this talk. And of course I obviously have not rehearsed it. I threw the slides together before the event. So forgive me if I'm a little bit choppy on the presentation. But I think we'll muddle through. Okay.
We are very thankful. Thank you.
Okay. So, I was trying to decide how to name this. And at first I thought, HSP, it's not just for kids, folks, and then I just thought, I think I'm going to make it a little bit more provocative. So I decided to call it The Forgotten Love Child. And I hope at the end of the talk, you might understand my reasoning on how she decided this weird title. Oh no, the first thing is I'm not able to advance my slide. Okay, this
I
is a
think you
problem.
should click on your screen first, then it starts to just click on it once.
Oh yes. Yeah, thank you. Thank you. Okay, so the objectives of the talk, we're going to review the histology and biology of IgA vasculitis. And I want to use those two terms interchangeably, IgA vasculitis and HSP. We're going to examine the genetics and the pathophysiology of the disease. We're going to discuss the treatment options and challenges in the framework of a real clinical case. And we're going to identify potential future directions for treatment. All right, just a little bit of history about HSP. So it was first described in 1802 by an English physician who wrote of a 5-year-old boy who was seized with pains and swelling in various parts, sometimes had pains in the belly, urine was tinged with blood, and skin of legs was all over full of bloody points. So that's a really nice synopsis of our disease. The disease was ultimately named after two German pediatricians, Doctors Henoch and Schonlein, who basically saw this as being syndromic, and they ended up getting the name for it. And that was back in 1860. And then 100 years after that is actually when we get IgA glomerulonephritis officially as a pathological, a distinct entity. And that, as you guys know, it was by the French pathologist, Dr. Jean Berger. And what's interesting about this history is that, even though we've known about, quote unquote, known about HSP since the 1800s, and IgA glomerulonephritis is actually a more newer disease, entity, if you will, we actually know a lot more about IgA glomerulonephritis than we do about IgA vasculitis. And I'm going to say that I might probably end this talk with a lot more questions than I have answers. But nonetheless, I think it is a worthwhile discussion. Here's another little excerpt from two English pediatricians. They describe identical 7-year-old boys who were afflicted by some viral infection. A few days later, one developed florid HSP with the GI symptoms, joint symptoms. He had nephritic syndrome. He ultimately got a kidney biopsy that showed proliferative GN with crescents. Then the second twin, again, afflicted with the same virus, had hematuria and some abdominal pain, but no rash. I guess he ended up with a biopsy as well that showed proliferative GN, and they thought the second twin had what was more characteristic of Berger's disease. So he writes, immunologic studies have not revealed why these identical twins responded differently to the same provocation. Perhaps Berger's disease may be considered a variant of Henoch-Schonlein nephritis. So the gauntlet was drawn at this point in the 1980s, to say, okay, what is it about these two? What is it about them that make them common? And what is it about them that make them different? In terms of the incidence of HSP, it does have a similar geographic incidence, if you will, obviously more common in the Asian continent and the least common in the African continent. In terms of classification, there are two classifications, the ACR and the EULAR. I kind of like the EULAR better because I think it's a bit more descriptive. So according to EULAR, it says you have to have purpura or petechiae and one of the following four criteria: abdominal pain, joint symptoms, renal involvement. And then histology has to show leukocytoclastic vasculitis with predominant IgA deposits or proliferative glomerulonephritis with predominant IgA deposits. Just a quick overview on the disease. As you know, it's certainly more common in children than it is in adults. And we do know the association, just like with IgA glomerulonephritis, we do know that IgA vasculitis or HSP is associated with infections. About 50% of the cases are preceded by an upper respiratory infection, especially those caused by streptococcus. And also through other provocations like insect bites and vaccinations. And of course, we know about the skin and the joint and the GI and the renal, but other potential rare organs that can be involved includes the scrotum, the central nervous system, the respiratory tract, as well as the eyes. In terms of the incidence of IgA vasculitis or HSP, as we go through the ages, it's not surprising to see that the incidence goes down the further out we get into our adulthood. So this table is about the difference between an adult getting HSP and a child getting HSP. It's a very busy slide, but I'm just going to point to some salient things that I want to say. So with the rash, oftentimes in children, it's considered self-resolving. It's, very fleeting. It's really very mild. Adults, very different story. It can be pretty destructive, and I'm going to show you some pictures. With the GI, both can get GI symptoms, but interestingly, children can get a very bad complication called intussusception, and that bears high mortality. And that's very rare in adults. Renal disease, we know in children, they can have some hematuria, of course, but most of the time it's kind of self-resolves and, it's no longer an issue. In adults, it often lingers on, meaning the hematuria, the proteinuria, and we have a slide on that as well. And then with regards to relapse, HSP relapse in child, often, pretty rare, I'm going to say. In adults, it's pretty common, and I'm going to go to that right next. So this was an interesting, hang on, I'm sorry. I'll go back. Okay. This was an interesting study, retrospective study from 2 years ago done by Dr. David Jane in the UK. And he followed the course of 85 adults that had HSP. And he basically followed them over a length of 4 years. And what I want you to notice is that even after 4 years from the initial insult, only about a third of the adult patients can say that they have complete remission of the disease. About 2/3 of the patients have still some lingering issues. So what are these lingering issues? So if you look at this slide here at the 48-month mark, a great majority of them have, residual renal conditions or CKD. And then a myriad of other extra renal residual symptoms as well. So again, this is just all to say that when adults get HSP, it is not necessarily a benign condition. I don't need to tell this audience about the pathogenesis of IgA. I'm just going to say IgA-related diseases. You guys know that the main issue is that we have these immune complexes that end up depositing in end organs, causing inflammation and disease. And we know that the substrate of this immune complex is the galactose-deficient IgA molecule, which we think is for the most part produced by the mucosa-associated lymphatic system. And of course, this is all in the setting of a permissive genetic background, okay? The diagnosis of HSP. Pediatrics is fairly straightforward, not so straightforward in adults. And that's just because many other diseases can present with little bloody points, if you will, on the skin that, ends up being LCV. I think you guys presented a case recently about LCV in a woman who might have been from a drug. So certainly hypersensitivity vasculitis can present as LCV. ANCA vasculitis can present as LCV. Cryoglobulin-related vasculitis can present as LCV. Polyarteritis nodosa, again, you know, what I'm trying to say is adults need a biopsy. And in the skin biopsy, what you're looking for is this neutrophilic invasion through the blood vessels. That's very important that they see that histologically. And then, of course, you guys know that on direct immunofluorescence, you have the deposition of the IgA. When do we do a kidney biopsy on these HSP patients? Certainly if the skin is non-diagnostic. And then also, I think that, you know, if you have severe or significant enough renal involvement, I think it's worth biopsying. And of course, you know, in adults, you know, when you work them up for a nephritic condition, you know, sometimes you can have, you know, some other serologies that can turn up that needs to be clarified. And that will be presented also. I don't need to tell this group about how IgA looks on the IF. So what's interesting is that there's a stain out there that actually can bind to the galactose deficient IgA moiety. And this is a stain called KM55. So this is just some pictures. Here's just a regular IgA glomerulonephritis case for the regular IgA stain. And this is the KM55, which stains the galactose deficient IgA moiety. And we see that in the same thing for a patient who has HSP vasculitis, you know, you have the staining of KM55. So it's the same bad person, you know, that's in this story. And this is just to show that in lupus, you know, of course, you know, lupus is a full house. So of course you're going to stain for, you know, all of the IgA, but for the KM55, you see that it does not stain. And then this is interesting because in the skin, if you were to make a little biopsy of one of the LCV lesions from the HSV patient, and you stain for KM55, you do see the presence of the Gd-IgA there as well. So that is an interesting thing that I just wanted to point out. I don't need to tell this group about the MES score, but I will also preface that this has not been validated in HSP vasculitis. HSP nephritis. I wanted to show this interesting scheme of, you know, histopathology classification. This is called the International Study of Kidney Disease in Children, and I believe it's used in the pediatric nephrology studies or you know, biopsies. And it's a grading system from grade 1 to grade 6. And, you know, when you look at the description of each grade, you see that, you know, they certainly concentrate a lot on the glomerulus, right? You know, they're talking about mesangial proliferation, they're talking about sclerosis, they're talking about crescents. But interestingly enough, there's no tubulo-interstitial discussion in this. But I just wanted to point this out because when you read the literature on HSP, this is going to be the grading system that you're going to see when they describe the histology of the patients. Okay, how and where IgA is made. So we know that the naive B cell, they are born in the bone marrow. From there, they go into the inductive sites, which are in our tonsils, in our respiratory tree, both upper and lower respiratory tree, in our in our gut, right? This is where the Peyer's patches is. And this is where they get exposure to the outside world. They get exposed to the mucosal antigen, gets the antigen presenting cell, activates the B cells, and they proliferate, they differentiate via both T cell independent as well as T cell dependent pathways, and you ultimately get a premature early plasmablast. And of course, we're focusing on the one that's going to give IgA, right? Because that's our disease. So, you know, this you know, early or pre-plasmablast goes into the highway system via the blood as well as the lymphatics. And then there they go into the effector sites, which is going to be the lamina propria in our intestines. There they get sort of worked on through these receptors at the basolateral end of the intestinal epithelial cell. And then ultimately they get scooted out into the lumen with this additional little secretory receptor. So the hypothesis in IgA-related diseases is that it is here where the polyclonal galactose-deficient IgA moiety gets back leak, if you will, back into the highway system, and then eventually traveling to our end organs. That's sort of the hypothesis, but I'm going to say that that's it's an ongoing evolution as to, you know, how that ends up in where they end up in terms of the molecule. So again, we're talking about the galactose deficient IgA, but it's actually the polymeric form that is pathogenic, not the monomeric form. And this is what is coming from the lamina propria. You guys know that, you know, we call it aberrant or pathologic is because they do not have these galactose sugars. So in essence, you have the exposure of these old GalNAc residues that actually become antigenic. And then we form antibodies against these residues, and hence we form these complexes. But interestingly enough, another way in which we form these, another possible way in which we form these antibodies is through something called molecular mimicry. And that is where, like for instance, where, you know, you have viruses and bacteria that we get that we come across. Interestingly enough, a few of the species actually express the GalNAc residue on their polysaccharide cell wall. So when we mount antibodies against the bad bacteria, you know, some of those antibodies can mistaken, you know, instead of killing the bacteria, ends up latching on to one of those galactose deficient IgA moieties. So that's just another way in which we may make these antibodies. I just wanted to review that IgA is considered a polygenic disease, which means that you have the finding of a lot of small alleles that each individually exert a small effect. And that's a very different thing as when you think about monogenic diseases, right? Like, you know, Fabry's or Alport's or PKD or whatever. So I just wanted to make that. Galactose deficient IgA, that seems to be, you know, a bad person in this story here. So interestingly enough, a GWAS study of about 2,600 subjects that had elevated Gd-IgA antibodies. So these would be patients as well as their asymptomatic blood relatives. When they studied the GWAS, they noticed that there were two signals that were of significance. And when they looked at these genes and they looked at, well, what protein is being coded by these genes, it turns out that they were being coded by an enzyme whose job was to actually tack on the galactose sugar onto the IgA backbone. So it was actually encoding this enzyme C1-Gal1T1 and its molecular chaperone cosmic. Okay, so just some background there. And we know that in IgAN, the concentration of Gd-IgA1 correlates with prognosis, because when you look at the renal cumulative survival, the group 4, which has the lowest renal survival, they also had the greatest serum Gd-IgA levels. So when I gave the talk on IgA glomerulonephritis a few years ago, I presented this GWAS study of 7,000 patients. And you know, they were, you know, I discussed a little bit about, you know, like for instance, genes that were encoding in you know, proteins important for innate immunity made perfect sense, since we think that this, you know, molecule comes from the mucosal defense system. When we saw an HLA, you know, allele, we said, oh, okay, that's not unexpected, because we know in essence, it is an autoimmune condition. And then of course, we know that, you know, complement is involved as well, right? Because that's where at the distal end of the pathway, that's where you get all the inflammation and all of the damage. So fast forward now to 2021, look at this now, look at the GWAS of the 10,000 IgA glomerulonephritis patients are included now. And look at this Manhattan plot. Look at how much more we know about IgA glomerulonephritis. So what about HSP? What about the GWAS study for those patients? You know, they're kind of left behind. So this was a small GWAS study of about 2,000 HSP patients spanning the continents. And well, at least we did pick up something. There were 2 genome-wide significant loci founding. Again, one in HLA, which doesn't surprise us, because in essence, it is just like the other. It's an autoimmune condition. And then it also showed this other one, which is coding for CD89, which we're going to talk about. Now, what didn't quite reach significance on GWAS, but what did take someone's attention was the allele that codes for interleukin-6 receptor. So they actually followed this up with what they call a proteome-wide association study. And they saw that when they did it that way, indeed, it did reach significance. So this is for soluble interleukin-6 receptor. And we're going to talk about interleukin-6 because apparently that is important in IgA vasculitis. In fact, I think we're going to talk about it right now. Okay, so interleukin-6. So how does this fit into this picture of HSP? So it really, in a nutshell, it enhances the production of the Gd-IgA formation. How does it do so? By a number of different ways. From the intracellular aspect, it does so via toll-like receptors. Toll-like receptors are part of our innate immunity. They've been identified as a receptor for bacterial and viral DNA containing a very specific sequence pattern. So they recognize certain patterns in the foreign invader. It binds to the receptor, it activates the receptor, and through a number of different pathways, you end up increasing the expression of both IL-6 as well as APRIL. Now, APRIL is something that we're going to talk about later, but the IL-6, we're going to continue on the story. So IL-6 then, via activation of the JAK-STAT pathway, translocate into the cell nucleus where it downregulates transcription of the C1 GAL-T1 cosmic, leading to synthesis of more Gd-IgA1. So this is what we were talking about just a few slides ago. And then when it comes to APRIL, we're going to talk about that. Now, I'm sorry, I think I have one more. Okay, here's another slide on IL-6. So interestingly enough, B cells express membrane-bound IL-6 receptors through their different stages. This looks like highest during the pre-plasmablast and plasmablast stage. Resting B cells normally do not express the membrane-bound IL-6 receptor, with the exception of the population of the GALT, the ones that are in our gut, which express the membrane-bound IL-6 spontaneously and respond to IL-6 by immunoglobulin production, preferentially of the IgA isotype. So again, this is just another way in which interleukin 6 helps really bump up the IgA population. And there's another way that we're going to also talk about IL-6, and that's going to be further down in the talk. So let's talk about CD89, because that was the other thing that showed up in the genetic testing. So CD89 is actually a surface receptor, and that's on the surfaces of myeloid cells, which include neutrophils, monocytes, macrophages, and eosinophils. And cross-linking of the CD89 by IgA immune complexes or IgA opsonized pathogens induces pro-inflammatory processes in the neutrophils, such as phagocytosis, production of reactive oxygen species, inflammatory mediators, cytokines, and chemoattractants. So basically, you have the attachment of the IgA immune complex to the receptor on the surface of this neutrophil. It activates the neutrophil to do a lot of bad things, okay? So that's sort of the story. So this is just another cartoon where you have the galactose deficient IgA, you have the anti-Gd-IgA antibody, you form all these complexes. These complexes are in the bloodstream, and they can tack on to the CD89 on the surface of this myeloid cell, and then the story goes on from there. Okay, and that's this is the beginning of the story, and we're going to continue the story, because this is in the blood vessels, right? And this is going to any organ, whether it be skin, gut, or wherever. But obviously, we're going to talk about the skin. So let's look at the role of CD89 in a skin disease model. And this is a model called LABD, which is linear IgA bullous disease. It is an inflammatory blistering skin condition caused by the presence of IgA autoantibodies that are against the collagen 17. And then, of course, you also see neutrophils coming in with the invasion and inflammation disrupting the normal adhesion between the dermis and the epidermis layers, and that's what causes the blistering. So on these top, you see the normal skin, nothing stains. And then these three frames, you see the people with the LABD, and they're staining for specific roles here that is part of the story. They're staining for the IgA, right? Because the IgA is an important player. It's binding to that collagen. It's staining to the neutrophils, which is being represented by this surface antigen CD66B. And it's also staining the CD89. I'm sorry, that's the same thing as CD89. Okay, so these are the important cast of characters that are here, causing this problem: IgA, CD89, neutrophil, and disease. So this has been sort of played out further in another animal model for LABD. Here, they took a mouse and they injected anti-collagen 17 IgA into the right ear, and these are all those injections, basically inducing the disease of LABD in this ear. And then for control, for the left ear, they injected a saline, okay? And then on days 7 and 11, they injected onto, I think to both of them actually, this compound, which is an anti-CD89 monoclonal antibody. And they just wanted to see whether or not this was going to attenuate any of the disease that would be formed. And indeed, it looks like it did. I mean, the pictures are not great, and I apologize for that. But this is supposed to represent the ear that has the LABD. And this is supposed to be after the injection of the anti-CD89. And it's supposed to show less neutrophil penetration into the area. And then this is supposed to show when they try to quantify the neutrophils, they try to show that there was less neutrophils going into the area of inflammation after adding this blocker. Okay. So how do we carry this story to HSP? How do we carry this on to HSP? How do we link this together? So this was done by the group by Jonathan Barrett, also in the UK. This was just published last year. And he tries to link the stories together as well as provide an ending to the story, okay? And what he introduces into the story is the concept of nets, which is called neutrophil extracellular traps, okay? And just a mechanism by which activated neutrophils externalize a fibrous network of web-like chromatin strands studded with various pro-inflammatory peptides and histones, okay? To release these nets, the neutrophils undergo a form of cell death, and then nets have been implicated in immune defense as well as in autoimmunity, such as SLE, RA, and ANCA vasculitis. Now, this is important because where have we seen nets before? Well, I know that in my lectures to the fellows, we've seen nets before, because this is my slide that I took from my ANCA vasculitis lecture. This is, obviously for a different disease, but there is a lot of similarity. So here you have a primed neutrophil with all of these antigens that are extruded out into the surface. You have these ANCA antibodies that bind to the PMPO, PR3. You activate the neutrophil. It goes through the cell death. You form the nets. You get the endothelial injury, and you get the vasculitis. So this is a very similar corollary story now to HSP. Okay, now to measure the presence of the nets, they stain for something called elastase, MPO, and HC-CIT, because those are the constituent proteins in nets. So this is what this is all about. They're basically, this is coming from the skin of the HSP patients, and they're staining for all of these players that we think are involved. Okay, so they're staining for IgA. They're staining for the endothelial cell, which gets damaged. The endothelial cell is the CD31 marker. They're staining for neutrophils, which is the CD15 marker. So here are all the players. You have the IgA, you have the neutrophil, you have the endothelial cell, and you have the nets, elastase, MPO, and the HC-CIT. So again, we have a cast of characters that kind of make this story a possibility. And then Okay, and then this is just to show the binding of the IgA complex onto the polys, and then you form the nets, and similar to the LABD model, they tried to add a CD89 blocker, and then they noticed that the proteinuria basically went down after adding this CD89 blocker. So again, the story is very similar. IgA complex binds to CD89 on top of the neutrophil, activates the neutrophil dies and goes through cell death and puts out the nets. And then here's the final story. The nets then kill the endothelial cells. Okay, the nets is the last trigger that is pulled to kill the endothelial cell and cause vasculitis. And this is just to show oh, I'm sorry, I'm mixed up here. Oh, that's here. Okay, that's here. I'm sorry. Let me go back. So, but that's the net story there. Okay, so this is the involvement of the cytokines in this story. Okay, to evaluate the possible role of cytokines in the priming of polys in HSP patients, several were measured, but only IL-6 and IL-18 were significantly elevated in the serum. And interestingly enough, set a net release after pre-stimulation of control polys with either IL-6 or IL-18, followed by IgA stimulation, shows that when you prime or when you incubate these polys with IL-6, and then you stimulate them, you actually get, even stronger and stronger net formation with increasing concentration of the IL-6. And apparently that was not quite seen as well with the IL-18. So again, this is where I had said that I was going to finish up the story for IL-6 for vascular HSP. This is where I'm finishing up the story for that. So again, this just to show that, okay, this is, again, we're just getting bits and pieces here, but this is what we're getting from the genome and the proteome study for the HSP patients so far. And this is just a nice picture to show the activated neutrophils that are on human umbilical vein endothelial cells. And then they get activated, and then you get the formation of these nets that are, so they're showing that this is really happening. This is not just something we're playing around, that we're imagining. So this is just another cartoon of ANCA. And then this is just the neutrophil that is basically dying and is extruding out these chromatin strands that are studded with these pro-inflammatory peptides. And by the way, this also acts as a scaffolding for complement activation too. All right, so we're trying to paint the picture that HSP is starting to smell like a vasculitis, a regular vasculitis. So this was an interesting genome study that was looked at. I think this is a Spanish group last year. What they did was they combined the genome data of pediatric patients that had HSP and pediatric patients that had another childhood vasculitis condition called Kawasaki. And they were curious to see if there were any parallels between these two. And it turns out that there was one. There was a genetic variant that codes for something in the function of lysozymes. So, but the main point to say is that, again, although there's a very close correlation with IgA glomerulonephritis and HSP, there's also an association between HSP and a vasculitis. This is a proteomic analysis of glomerular proteins that were extracted from kidney biopsies from both patients that had IgA glomerulonephritis and patients that had HSP nephritis, okay? And you can see that, again, yes, obviously a lot of the proteins are similar, but there are a few outliers that make them different, and we need to find out more about what makes them same and what makes them different. Okay, now let's get into the clinic. But before we go into the clinic, let's just say, okay, so what do we know so far about how to treat my patient? I'm going to meet this guy, but how do I treat him? Well, what does KDIGO say? Well, I'm going to tell you, KDIGO is telling you squat. Okay, they're basically saying we don't know much about IgA vasculitis nephritis, and we're going to extrapolate what we're going to tell you by looking at what we do for IgA glomerulonephritis, okay? And basically these are copied straight off of the KDIGO. So, the long and short of this thing is that I want you to know that when you see an adult with IgA vasculitis, please screen them for cancer, because there is an association between HSP and both solid tumors as well as hematologic malignancies, okay? So just do that for the adult patients. And then this is just saying that, just to let you know that the MES score is not validated for IgA vasculitis, nor is the international prediction tool validated for IgA vasculitis. For people who do not have RPGN, you do all the usual things for IgA glomerulonephritis. For people that are higher risk for progressive disease, they say, well, you can consider glucocorticoids. And then for people who have rip-roaring RPGN, you can treat them like you would do for ANCA-associated vasculitis. Okay, let's go into the clinic. Armed with as much as that, we go into the clinic. And we meet my patient, Charlie. He's a 38-year-old gentleman. He has a history of HIV, but he actually has been well controlled with undetectable viral load for a long time. He recalls having some sort of URI, and then a few days after that, he had a rash, also some joint pains, some sinus congestion, some anorexia, but obviously he's referred to me because he has microscopic hematuria and proteinuria. And you see his numbers. His baseline creatinine is just at 1. So he does have a mild renal insufficiency. Pretty impressive albuminuria, right? 2 grams. And he sort of has lukewarm serologies, low positive ANA, obviously negative DSNA, negative complements. Otherwise, I would have already told you that. He has this positive atypical p-ANCA, which I have absolutely no idea what to make of. Obviously, the MPO and the PR3 were negative, or else I would have already told you. He gets all the biopsies done, and the bottom line is that he gets the diagnosis of HSP/IgA vasculitis with nephritis. So, I'm sorry, these are some of, and this is actually my patient, okay? This is Charlie. Some of them coalesce into, these plaques, if you will. This was right above his left ankle, and this was actually a big blister. He blistered out. It actually got super infected. So this was above the left ankle. And let's see what's on the right ankle. Look at this. This was actually necrotic. He actually had to go to wound care to get this debrided. So again, in the adult population, this is not a benign condition. So, in thinking about treatment, I thought, well, since this is predominantly a pediatric condition, let me look at the pediatric literature to see if it's going to be of any help. Well, so this was a systematic review from 2007. And I'm going to tell you the bottom line was that it wasn't of great help. This was to look at, the effects of adding corticosteroids in treating HSP, okay? And this is in kids. The average age of the patients that were here was about 10, all right? So, I mean, I don't mean for you to look at these at all. This is just to show that, that we had studies that were on both sides of the aisle. Some were helpful, some were not helpful. And it was just, first of all, very few prospective RCTs. The majority of the studies were retrospective case series, case reports, with all of the inherent problems with having retrospective studies. And even the endpoints were very odd, because they would send mom home with a diary and say, okay, tell us little Johnny's belly pain, after taking the steroid. And of course, mom is filling this out. And mom is also doing the dipsticks at home and, saying, oh yeah, the blood is now +2. And yesterday it may be +1. There was very few, UPCRs, and there were certainly no 24-hour collections at all in any of the studies. So unfortunately, that didn't really help me. And then what about in the adult literature for HSP? Well, I'm going to say that it wasn't that helpful either. Again, most of the studies, this is just a snapshot of what's available, but most of the studies were retrospective studies. There was only one prospective randomized control study that we're going to review. So again, not too helpful. So I'm going into this blind, okay? So Charlie, he actually ends up going to the ER before he comes to see me and follow up for the kidney biopsy. I think one of his ankle sores just, maybe started leaking, or I'm not sure, pain or joints or something. Something brought him to the ER, and they ended up giving him a one-time dose of prednisone, 60 milligrams, and sent him out and said, okay, you need to follow up with all these people. He follows up with rheumatology before he sees me and is put on prednisone. I believe he was put on, I think he was put on 60 milligrams. I may be wrong, but when I saw him, he was at least on 60 or 50 milligrams. And of course, we put on all the usual ARBs and ACEs to control the blood pressure, and the proteinuria did improve. But the main thing that we were contending with was his skin. These skin lesions were unabating. We were not able to lower the prednisone below 40 milligrams per day. Each time we tried, even going, to 35, or, he would call and say, I have another fresh crop of skin points. So anyway, dermatology decides to add dapsone onto the regimen. And but unfortunately, about 2 weeks after starting dapsone, he runs into trouble. He calls and says, I don't know what's going on, but I can't get my heart rate down below 110. I'm a little bit short of breath. And I'm like, well, you got to get yourself into the ER, because I don't know what's going on with you. I don't know if you may have, diffuse DAH, diffuse alveolar hemorrhage related to this, HSP or whatever. I don't know. So anyway, in the end, he was found to have methemoglobinemia. And so the dapsone had to be stopped, and then colchicine was started in place. So I thought this would be a good place to talk about colchicine and dapsone. So colchicine is derived from a crocus plant, and it's been used for quote unquote rheumatism for a long, long time. We really know it more as a gout medication. Its mechanism of action is basically its ability to perturb the microtubule function of the neutrophil cytoskeleton. So basically, it inhibits the motility of the neutrophil. Okay, we all know about the side effects of diarrhea and all that. And then, as you know, it is used in rare chronic inflammatory conditions such as familial Mediterranean fever, Behçet's disease, and pericarditis. And this is just some, this is a case series of people that used colchicine to treat chronic LCV. And this is LCV from many different things, not just HSB. There was some lupus, there was some from some drug, dye, there was some from, rheumatoid arthritis, idiopathic. So they found that, colchicine was effective. Okay, dapsone. Dapsone, it is an antimicrobial, anti-protozoal agent. We know it as using for prophylaxis for PJP. But, similarly to the colchicine, it also affects the motility and the activity and action of the neutrophil. It also decreases prostaglandin production, which in that way makes it almost like an NSAID. Let's see, and it's metabolized hepatically by two routes, via the acetylation route and the hydroxylation route. And then it is actually the dapsone hydroxylation metabolites that can be taken up by the red blood cells, where it can act as a reactive oxygen species and cause methemoglobinemia. So that's an important thing to look out for. And of course, most of us do know that you can have a hemolytic anemia, especially in patients that are 6-GPD deficient. It's just another cartoon in which how dapsone interacts the neutrophil, and I'm going to say colchicine does the same thing too. And this is just a case series of patients using dapsone and HSP, and they all did well, and they were put on it for various lengths of time. Okay, so we're going back to Charlie. So he, dapsone is out, colchicine is in. Is it working for us? The answer is no. Still not able to wean that prednisone. Creatinine, meanwhile, is stable, and the UACR is improved. So what do we do? What do we do with this guy? We can't leave him on, 40, 50 milligrams. And at this point, he was starting to gain weight and all that. So anyway, after much discussion with the patient, we decide to try rituximab. And so 2,000 milligram load was given, and we watched and waited. So what do we know about retux? So in the IgAN literature, IgA glomerulonephritis, this was a small study about 6 years ago now by Lafayette. And it was small. I mean, it was it was an open label study, prospective, and there were 17 patients control, 17. I mean, I say small because these days IgAN studies are, for what DAPA was 270, I think, and then for AMPA is like 800. So, again, this is you take it for what it's worth. And then the baseline characteristics were not exactly equal, because here in the GFR, the baseline, that was statistically significant difference. It was lower in the rituximab group than it was in the control group. But nonetheless, whatever, I mean, it was a negative study. There was no change in the proteinuria. There was no change in the eGFR. Okay. A year later, Maritati does another, well, this one is going to be retrospective, but he looks at how adults did with adding on rituximab, like I would do. Now, this is a small study, 16 patients. All in all, it's a small study. So basically, it was a positive study because the inflammatory markers went down. The prednisone dose was allowed to be titrated down. The proteinuria went down, and the eGFR was stable. What do we know about cyclophosphamide and IgA and HSP? Well, so this was the only prospective randomized control study that was in that list there, and this was done by Pillebalt, who is in France. So what she did was that she, I believe this is actually open label, but there were two groups, a steroid arm and then a steroid arm with the addition of several pulses of cyclophosphamide. And again, small study, there were only 25 that had the cyclophosphamide and 29 that just had the steroids. And these people were sick. I mean, everybody had their skin involvement. About half of the people had the GI involvement. Half the people had the joint involvement. And then, of course, everybody had the nephritis involvement. And so they were followed for 12 months. And basically, the bottom line is it was a negative study. They did not feel that adding cyclophosphamide added much on top of the glucocorticoids in this group of adults, that had fairly significant HSP. Okay. So anyway, so we try them under rituximab, and I will say, thank goodness, we were able to slowly taper down the prednisone. And then after 6 months, I thought, okay, what do we do with him at this point? I said, you know what? This was a horrible ordeal that he went through, and we don't want this to happen again. So I'm going to put him on a maintenance treatment. Okay, there's nothing to say that this is what I should do, but I decided this is what I'm going to do. And he was okay with it because he certainly did not want to go through this ever again in his life. So we put him on mycophenolate, 1,000 BID. And now he's been titrated down to 500 milligrams BID. So I think I'm just going to keep him there. We were able to stop the colchicine after we got him off the prednisone. These are his latest numbers, and all the wounds have been healed. So that's the story for okay, the story on mycophenolate in HSP. So this was an Asian study. This was also retrospective, fairly small study. And it basically looked at two arms, one that used MMF with a reduced dose of corticosteroids, and this is using standard dose of corticosteroids. And they followed them out. And again, you see the histology, this is the ISKD, the other classification, okay. Anyway. Okay, yeah. So in follow-up, it was considered a positive study. In 6 months, you see both groups showed equal decreasing in the degree of proteinuria for both treatment groups. So, again, this is an Asian study. They were saying that, yes, you could use MMF with reduced glucocorticoids. This is just to remind me to say that, yes, you could plasmapherese these patients, just like you would with ANCA vasculitis. This was a small retrospective study that looked at 11 patients, and basically was TPE added on top of high-dose glucocorticoids. They gave on average about 12 treatments, And they followed them out. But the bottom line is it was a positive study. These patients' proteinuria got better, their eGFR got better. Okay, so this is just to kind of round things up. So we know that the landscape is bountiful for IgA glomerulonephritis, and I don't need to tell this group about Tarpeyo or sparsentan. You guys have already heard about that. But what you might not know is that none of these studies recruited HSP patients. It is an exclusion to all of these clinical trials, okay? And that's a problem. It's a big problem. And so going forward, we need to say, okay, what is something that is similar to both entities that may have use for the vasculitis patients. So, we often talk about the Gd-IgA, right? Gd-IgA is seen in both. We see it on the skin, we see it in the kidney, we see it, we see it in those two main organs. So the Gd-IgA seems to be the problem. So why don't we talk about how can we target lowering Gd-IgA? Okay, so for that, we're going to talk about the B cells. So, part of the reason perhaps maybe the rituximab didn't work so well, maybe is that, after this early plasmablast stage, the B cells stop expressing the CD20 surface receptor. So the rituximab is not going to hit these later stages. However, these other B cell surface receptors are important. They are important in allowing these B cells to become the mature plasma cell, the BAFF-R, the TACI, and the BACMA. So we're going to be talking about these B cell surface receptors, okay? The ligand for those receptors are the compounds APRO and BAFF. They're both members of the superfamily cytokines, the TNF superfamily of cytokines. Okay, and they basically work on these receptors. APRO works on BACMA and TACI, and BAFF works on BAFF-R and TACI. Okay, and it's interesting that when you look at the GWAS study, it turns out that the gene that codes for APRO, which is TNSF13, is actually a risk locus for IgA. So let's go back. Let's go to that busy Manhattan plot. There it is right here. Here it is, the TNSF13. So APRO is genomically important in this whole story. But BAFF is important too. And they saw that when they made transgenic mice that were able to overexpress BAFF, and raised them in commensal, it was exposure to commensal flora. They actually developed an IgA-like glomerulonephritis. You see these glomerulus becoming more proliferative, and you stain them, and it's IgA dominant. And it just shows that if you raise them in germ-free, they do not develop this condition. They actually have to be exposed to other bacteria. And then, of course, you see the proteinuria that occurs when you get this condition. However, if you attenuate or knock out their ability to make IgA, the proteinuria is decreased. So again, BAFF is important in the story also. We know within IgA glomerulonephritis, there's a proportion like there's a high BAFF concentration in patients with IgA glomerulonephritis compared to, this is actually healthy subjects. And then similar for APRO, higher concentration in the IgAN patients correlates with proteinuria and with eGFR. Okay, so with that in the background, let's jump to the present time. So this was produced, I think, right at Thanksgiving, and it was in the New England Journal of Medicine, and it looked at the ability of this particular product. I'm just going to call SIB. This is an anti-APRO monoclonal antibody compound. It's actually an infusion. It's given, I believe, monthly, once a month. And so the study was for 12 months, and they wanted to see how this was going to work in IgA. So not surprisingly, you did see the diminishment in the Gd-IgA levels But, after you stop the study, the Gd-IgA level goes back up again. Of course, because you're affecting B cell proliferation and differentiation, you do get a decrease in IgG and you do get a decrease in IgM. But what's important is that it didn't meet its primary outcome of decreasing the proteinuria at all the doses, actually, at least 50% decreasing the UPCR. And what's important, obviously, when you're decreasing all of these immunoglobulin producing cells or, affecting them, is that you want to make sure there's no adverse effect. And so far, there is no adverse signal that's been seen. Let's talk about atacicept. Atacicept actually blocks both BAFF and APRIL, so it blocks all of those receptors, okay? And this was a phase 2 study. This has not been published out, but it was presented in one of the European Congress meetings. And it looked at atacicept at various doses against placebo, and they were looking at the data point at 36 weeks. Baseline, most of them had, mild CKD, and they had at least 1 gram of proteinuria. And of course, you see the nice Gd-IgA diminishment. And just like with the other product, you see the IgG and the IgM go down as well. And importantly, you see the decrease in the UPCR, the change of 34%, and a fairly stable eGFR course. And so far with again, no signals for adverse reactions on atacicept. So this is the Origins 3, which is the phase 3 study of this. And we are, whenever I get well again, we are going to be a recruiting site for this study. Okay, it's a randomized placebo-controlled study against the highest dose against placebo to 104 weeks. And there's going to be an open label extension. So I just want to end the talk by saying again, to say the genetics are important, because when you round up a big population of patients with a specific disease and you look at their genes, and if there are a few alleles that are similar and significant, and you can look at that gene and you can look at the protein that's encoded, look at the cell that's making this protein, you can map out a biologic pathway by which you can potentially target different points along that pathway as for drug development, and this is just to show for IgAN, these are all the risk alleles, these are candidate targets and even related targets that you can potentially work on. So in the complement space, we know that there are a lot of complement studies going on in IgA glomerulonephritis. And then we talked about APRIL and we talked about, BAFF. So this is how we use the information. And with IgA specifically, for HSP specifically at now, there's a lot more genome-wide studies that we're going to have to do. But at this point, it's very interesting that IL-6 pops up as being a proteome significant. And there was a question about whether or not we can repurpose a IL-6 inhibitor, tocilizumab, for use in really refractory HSP patients. This, by the way, is presently used in, I think it's used in rheumatoid arthritis, giant cell arteritis, and I think it's also being used in COVID for the cytokine storm. Again, all of these studies, we're so wealthy in IgA studies. This is the Vera study, but none of it is including IgA vasculitis. There's only one study actively recruiting adults with HSP, and that's in France, looking at the use of glucocorticoids and rituximab versus placebo, meaning I guess just versus glucocorticoids alone. So that's why I call it the forgotten child. And I call it the love child because I'm thinking of HSP almost as IgA glomerulonephritis getting together with ANCA vasculitis and having an offspring. And that's how I'm thinking of HSP at this time. I think more will be known as we go on, and we'll know better how to treat this disease.